Welcome to this next video in which we are discussing sarcoidosis. Okay, so we're in the process of discussing the pathogenesis of tuberculosis because, as I've previously stated, I think the best way to gain an understanding of what happens in sarcoidosis is by studying tuberculosis, because what you have to understand is a lot of the parts of the pathogenesis of sarcoidosis have holes in them, and I think that looking at the pathogenesis of tuberculosis, which involves the formation of very similar granulomas to what occurs in sarcoidosis, is the best way to initially gain some understanding of what actually might be happening in sarcoidosis. Don't worry, after we've studied tuberculosis we will come back to sarcoidosis and we'll have a look at the different theories, well, the two major theories of what actually is causing sarcoidosis, one of which actually says that it is actually just part of tuberculosis, and the second of which is completely different and involves propionibacterium acnes. Okay, so for now then, back to the pathogenesis of tuberculosis. So remember, what has happened is we have breathed in loads of mycobacterium tuberculosis bacterial cells, and these have gone all over our lungs. So they're now in the alveoli of our lungs all over the place. And the first response that occurred was that the alveolar macrophages and the alveolar dendritic cells were going to phagocytose the mycobacterium tuberculosis cells, and they were going to attempt to destroy them through this process. However, we've discussed that that process unfortunately goes wrong. Mycobacterium tuberculosis gets the better of the macrophages and the alveolar dendritic cells. It stops the actual destruction process. It gets engulfed absolutely fine, but it stops the destruction process. It stops the lysosomes from fusing with the phagosome, and it stops the production of reactive oxygen species and reactive nitrogen species, and therefore the mycobacterium tuberculosis cell can actually survive in the phagosome, and it even starts dividing inside the phagosome, and it can cause the phagocyte to burst open and release the cells into the extracellular fluid, and the cycle will then repeat again. So overall, the alveolar dendritic cells and the alveolar macrophages have totally failed to deal with the mycobacterium tuberculosis cells. So what now happens is they call for help. They call for the inflammatory response to begin. So we're now going to discuss the inflammatory response to mycobacterium tuberculosis. So, the inflammatory response is all about trying to bring in troops to deal with a pathogen that is currently invading a certain portion of tissue. Now, all the troops that can come and help clear a pathogen that is infecting a certain tissue are within the bloodstream. So the inflammatory response is all about recruiting troops from the bloodstream into the extracellular fluid at the site of infection. So it's fundamentally a response of the microvasculature. Okay, now, to initiate an inflammatory response, what has to happen is you have to release molecules that are pro-inflammatory. These are effectively the alarm signals that the alveolar macrophages and the alveolar dendritic cells are going to release to tell the microvasculature, we need an inflammatory response, you need to bring in troops from the blood to help us deal with this, we can't cope. So let me draw an alveolar macrophage then here. Okay, so this is an alveolar macrophage, and the release of these pro-inflammatory mediators is actually going to begin the moment it recognizes the presence of mycobacterium tuberculosis, but it will certainly start to increase as the mycobacterium tuberculosis population increases, because the alveolar macrophages and the alveolar dendritic cells have failed to actually get the infection under control. So here's our alveolar macrophage, and it's going to start releasing loads of pro-inflammatory mediators. There are absolutely loads of these that you can go away and learn. However, I'm going to give you just the two major ones, the two most important ones, the ones that if you're not going to learn any other pro-inflammatory mediators, you must know the names of these two. The most important ones, TNF-alpha and IL-1. So these names stand for tumor necrosis factor alpha is TNF-alpha, So T for tumour, N for necrosis, F for factor, and then it's tumour necrosis factor alpha. There are other tumour necrosis factors which are nowhere near as important as TNF alpha. So tumour necrosis factor alpha is going to be one of the molecules that you release, and IL-1 stands for interleukin-1, meaning between leukocytes, which are white blood cells, and it's a signalling molecule that's going to be released and act between white blood cells. Okay, so these are both proteins. TNF-alpha and interleukin-1 are both proteins that the alveolar macrophages and the alveolar dendritic cells are going to start synthesizing. Now, we can call them pro-inflammatory mediators, or you can even call these two pro-inflammatory cytokines. The word cytokine means a protein that is released by a cell of the immune system that is going to have an effect on another cell. Okay? So it's just a signaling molecule that is specifically released by a cell of the immune system, and it has to be a protein. So people often get confused about the term cytokine, so I'll repeat it again. It is a protein released by a cell of the immune system, which an alveolar dendritic cell or an alveolar macrophage certainly is, which is going to affect the behavior of another cell, and the cell that it acts on does not need to be a cell of the immune system. So TNF-alpha and IL-1 are certainly pro-inflammatory cytokines. They've been released by a cell of the immune system, they are protein molecules, and they're going to affect the behavior of cells of the microvasculature, which are not cells of the immune system. To generalize slightly, you could also refer to them as pro-inflammatory mediators. This is slightly more general because mediator doesn't imply that these are proteins. In these case, the two that I've mentioned here, TNF-alpha and interleukin-1, they are both proteins, so you can refer to those as cytokines. But as I said, there's loads of them that I'm not actually mentioning here. I'm just giving you the major two, but there are loads of other molecules that the alveolar macrophages and the alveolar dendritic cells will release at this point, which will also have a pro-inflammatory effect, and some of those are not protein molecules, and therefore, to generalize, you can call them pro-inflammatory mediators. Okay, but these are the two major pro-inflammatory mediators, TNF-alpha and interleukin-1. So when the alveolar macrophages and the alveolar dendritic cells detect the presence of the Mycobacterium tuberculosis, they're going to start releasing these molecules which will call for help. As the population of Mycobacterium tuberculosis goes up, because the alveolar macrophages and the alveolar dendritic cells are failing to deal with the infection, then their release of these molecules will go up even further. Okay, and these molecules are effectively the call for help. They are the alarm signal. They are saying, Mayday, Mayday, we need help here. We cannot cope with this. We need you to bring us troops from the bloodstream to help deal with this infection. Okay, so TNF-alpha and interleukin-1 are now going to cause the inflammatory response. And the inflammatory response, as I've said, it's fundamentally a response of the microvasculature, because the microvasculature is what is going to be able to move troops from the bloodstream into the extracellular fluid. So that's where TNF-alpha and interleukin-1 are going to act. They're going to act on the tiny blood vessels in the affected area. In this case, they're going to act on the tiny blood vessels in the lung. So what I just want to do now is give you a brief reminder of the different types of microvasculature blood vessels. I think this is really important for having a full picture of what actually happens in the inflammatory response. So we're just going to have a little recap of the microvasculature blood vessels. So we begin then with the terminal arterioles, which I'll draw here. The terminal arterioles then split into capillaries, like so. So I've got it splitting into 3 different capillaries here, which are even smaller, and then the capillaries will reconverge up to form a post-capillary venule. So here's the basic picture. So this blood vessel here, this is on the arterial side, and this is what we would call a terminal arteriole. So this word, arteriole, it covers a huge scope of different sized blood vessels. It's a very bad word to use because Some arterioles are absolutely massive. They're only just smaller than arteries. This type of arteriole that I'm referring to here as part of the microvasculature, this is absolutely tiny. It's only just bigger than a capillary. It's the arteriole just before you then split into capillaries. And to emphasize the fact that we are talking about one of these tiny arterioles just before you split into capillaries, we can stick the word terminal in front of it. So this means the last arteriole before you actually split into capillaries. And then now, in green here, we can see that the terminal arteriole has split into lots of capillaries here. So these are the capillary blood vessels, and we could refer to the whole thing as the capillary bed for that terminal arteriole. So these are capillaries, and I'll call the entire thing the capillary bed of the terminal arteriole here. And then the capillaries are all going to reconverge up to form a large venous blood vessel, and this now is what we can refer to as the post-capillary venule. So again, the word venule is a bad word to use because it covers a huge scope of different sized blood vessels. There are venules that are only just smaller than massive great veins, and then there are these venules that we're referring to, which are the venules immediately after capillaries, which are absolutely tiny. So this is a post-capillary venule. So you can put this description in front of the word venule to clarify. This is a venule immediately after capillaries, post-capillary. Okay, so those are the basic blood vessels of the microvasculature. What I would just like to do now is have a look at the wall structure of each of these three types of microvasculature blood vessel. So I'd like to take a cross-section across the terminal arteriole, a cross-section across the capillary, and a cross-section across the post-capillary venule, and have a look at the layers of the blood vessel wall of each of these three microvasculature blood vessels. This will be important for us to be able to understand the inflammatory response. So, let's have a look at the terminal arteriole first. So, we'll start from the inside and work out. So, this line can represent the basement membrane of the endothelium. So the inner lining of the terminal arteriole, the lining that will actually face into the lumen of the blood vessel, this will be the endothelium. So it will consist of a basement membrane with endothelial cells sitting on top of it. So in red there, that's the basement membrane, and these cells that I'm drawing now inside of the basement membrane, these are the endothelial cells, like so. So this is the endothelium layer of the terminal arteriole. So I'll just label up a few things here. And these are the endothelial cells, so I'll just label them as ECs. And in red, this is the basement membrane. Now in the case of the terminal arteriole, we don't stop there. There is another layer outside of the basement membrane, which is a smooth muscle cell layer. Okay, and this will consist of lots of smooth muscle cells, which are these spindle-shaped cells, like so, which will arrange themselves in circular arrangements like so. So these are smooth muscle cells, and overall these are called vascular smooth muscle cells. VSMC is for short, vascular smooth muscle cells. Now, if you can imagine what will happen if all of those vascular smooth muscle cells in this loop here were to contract, what would happen? Well, they'd all shorten in length. Each one of them would become less long, so it would shorten in length. And them all shortening in length would mean that the circumference of that ring would decrease. So when the length of all of these vascular smooth muscle cells decreases, the length of that entire ring, the circumference of the entire ring of vascular smooth muscle cells would decrease. And when the circumference of a ring decreases, the diameter of that ring decreases. Okay, so these vascular smooth muscle cells, by contracting, they can constrict the lumen of the blood vessel. They can control the diameter of the lumen of the blood vessel and thereby control the amount of blood that is flowing through the capillary bed. Okay, so it's very important to understand then that the terminal arterioles have a layer of vascular smooth muscle cells surrounding the endothelial layer, and that this controls the diameter of the lumen of the terminal arteriole and therefore controls the amount of blood that will be flowing through the capillary bed. Okay, so that's the structure of a terminal arteriole. Now let's go even smaller and draw the structure of a capillary. So we've taken a cross-section for a capillary, we'd end up with something absolutely tiny in this case. So drawing it in scale with the terminal arteriole, it would be this sort of size. So here's the basement membrane, and then you might just have a single endothelial cell making up the entire surrounding here, like so. So these are really tiny little blood vessels. Their entire circumference can be spanned by a single endothelial cell in this way, and they have nothing outside the basement membrane. Their wall is this very simple structure just consisting of an endothelial cell layer and then the basement membrane. So they just consist of the endothelium, like so, and they are tiny little blood vessels. The size of the lumen here is just large enough for a single red blood cell to fit through. Okay, whereas we can see that the size of the lumen of a terminal arteriole is much, much larger. Okay, so there's the cross-section of a capillary. Now let's go up to a post-capillary venule. So their wall structure is actually just a bigger version of, it's actually very similar to the wall of a capillary, and they are just effectively bigger versions of the capillary. So here, this is once again the basement membrane, and now let me draw the endothelial cells sitting on the basement membrane. So here, these are endothelial cells, and that's it for the wall of a post-capillary venule. So they don't have anything surrounding the basement membrane either, so they're effectively just bigger versions of the capillaries, okay, just with much larger lumens that can fit, quite a few red blood cells inside, okay? So of course the capillaries are where gas exchange is going to occur. Oxygen will come out, carbon dioxide will go in. Oh, sorry, no, we're talking about the lungs in this case. So start again. Microvasculature in the lungs, capillaries, these are the pulmonary capillaries, this is where gas exchange will occur, and in the pulmonary capillaries, oxygen is going to be coming in from the alveolar spaces into the capillaries. So if I just draw the alveoli here as well, so let's say this is the basement membrane of an alveolus, and the basement membrane of the alveolus will be continuous with the basement membrane of the capillaries, and then of course we'll have some type 1 pneumocytes lining the surface here. Okay, so you'll then have gas exchange, oxygen will come in, carbon dioxide will go out at the capillaries, and we're now going to discuss the inflammatory response and how it's going to affect all of these different microvasculature blood vessels. Right, okay, so TNF-alpha and interleukin-1 have been released by the alveolar macrophages and the alveolar dendritic cells, so they're going to be going up in the extracellular fluid surrounding here, and they're going to now go and act on the terminal arterioles, the capillaries, and the post-capillary venules, and they're going to cause different effects at these different sites. So what's the effect that TNF-alpha and interleukin-1 are going to have on the terminal arterioles? And I would just like to complete this picture up by putting one of these alveolar macrophages here, and it's going to be releasing these molecules, and they're going to be having an effect on all of these different vessels of the microvasculature here. So here's our alveolar macrophage, and here is the alarm signal in the form of this interleukin-1 and tumor necrosis factor alpha molecules going and acting on the microvasculature blood vessels. So what's the effect then on the terminal arterioles? Well, the effect on the terminal arterioles is to cause relaxation of the vascular smooth muscle cells. Now, these molecules do not cause relaxation of the vascular smooth muscle cells directly. Instead, they actually act on the endothelial cells of the terminal arterioles and get them to release molecules which will then cause relaxation of the vascular smooth muscle cells surrounding them. However, the overall effect of TNF-alpha and interleukin-1 is to cause relaxation of the vascular smooth muscle cells surrounding the terminal arteriole, and therefore vasodilatation or vasodilation of the terminal arteriole. That will lead to increased blood flow to the affected area. So vasodilation will occur, and this will lead to blood flow going up. Now, what's the significance of that? Why do we want blood flow to go up? Well, remember what the purpose of the inflammatory response actually is. The purpose of the inflammatory response is we are bringing in troops from the bloodstream to the affected area to fight the pathogen that is present there. Okay, if we've got more blood flowing through the capillary bed at the affected area, then the opportunity to recruit troops from the bloodstream into the affected area is going to be much greater. So the potential number of troops that we can recruit from the bloodstream into the affected area is going to be increased by having increased blood flow. So blood flow goes up. So that's the reason that we want the terminal arterioles to vasodilate. Next, let's have a look at the effects that TNF-alpha and interleukin-1 are going to have on the capillary bed and post-capillary venules. So the effects that it will have on these two are identical. As far as the inflammatory response is concerned, these two are going to do exactly the same thing. Okay, so one of the things that's going to happen is endothelial contraction. Now, what is meant by endothelial contraction? Well, let me explain by telling you about how the junctions between the endothelial cells are usually operating. So if I draw a picture of the endothelium of a capillary or a post-capillary venule here. So here's my little picture here. So this is the basement membrane in red once again. And on top of the basement membrane we'll then have the endothelial cells. Now usually in these capillaries and post-capillary venules, the junctions between neighbouring endothelial cells are quite tight. Okay, so there's usually a quite tight junction here that doesn't allow much to come from the bloodstream through that junction and then into the extracellular fluid. In response to TNF-alpha and interleukin-1, what's going to happen is you're going to get endothelial contraction, where these endothelial cells are going to contract effectively. They're going to withdraw their peripheral processes and open up gaps in between themselves and neighbouring endothelial cells. So this is what's going to happen after endothelial cell contraction has taken place. You can see that the endothelial cells have withdrawn their peripheral processes and they've now opened up gaps in between themselves and the neighbouring endothelial cells. So, endothelial cells in the capillaries and the post-capillary venules near this affected area are going to undergo endothelial contraction, and what this is going to allow is it's going to allow fluid from within the bloodstream to leave the bloodstream and go into the affected area. And this fluid is going to allow it's going to allow proteins from within the blood to move with it. That's the really important thing here. These gaps and the basement membrane are going to actually allow proteins as well as just fluid from the bloodstream to move through this layer and then get into the extracellular fluid of the tissue. And when you form this fluid that is protein rich from the bloodstream, that is known as an exudate. Now let me stress that the gaps are not big enough for the actual cells of the bloodstream to move through them yet. We'll talk about that in a moment. But they are big enough to allow fluid to move through, and the proteins from within the bloodstream can also leave the bloodstream and go into the extracellular fluid. And this combination of fluid with a lot of the proteins from the bloodstream is known as an inflammatory exudate. So you're going to start getting an inflammatory exudate forming in this area. Loads of fluid is going to be leaving the capillaries and the post-capillary venules and coming into the affected area. And it will ooze through the alveolar epithelium here and into the alveolar spaces. So you're going to get inflammatory exudate forming in the alveolar spaces. Now what's the purpose of this? Well, in the blood are loads of proteins that are capable of attacking pathogens. The major example are the complement proteins, which are capable of initiating the complement cascades which can kill pathogens. So this is the reason that in an inflammatory response, endothelial cell contraction and the formation of an exudate occurs to bring in proteins from the bloodstream into the affected area that will be able to actually attack the pathogen. Okay, so that's the formation of exudates. So we're going to bring in proteins from the bloodstream into the affected area which will be able to attack the pathogen. Not particularly effectively, it has to be said, in the case of mycobacterium tuberculosis, but in the case of other bacterial infections, the complement proteins will have far more of an effect. Okay, and the other thing that the capillary bed and post-capillary venule endothelial cells are going to start doing is recruiting white blood cells. So the fancy name for white blood cells is leukocytes. So we're going to get recruitment of leukocytes, known as leukocyte recruitment. Okay, so I said that these gaps in between the contracted endothelial cells were not big enough for white blood cells to fit through on their own. However, they are still going to move through those gaps, but they have to get help from the endothelial cells. Again, this is the reason that red blood cells are not going to start coming out of the bloodstream and going into the affected area, because they're not going to get the help from the endothelial cells. So, let me show one of the major types of white blood cell that you're going to be recruiting from the bloodstream. So one of the major types you're going to be recruiting is known as the neutrophil. So neutrophils are another phagocyte. They are not a phagocyte that you have stationed all the time in tissues. So we've discussed how the lungs, for instance, has these resident phagocytes, these alveolar macrophages and these alveolar dendritic cells. You don't have resident neutrophils. These are the emergency cells that are brought in huge numbers when you've actually got an infection at the tissue site. But they're also phagocytes, just like the dendritic cells and the macrophages. So let me draw a picture of a neutrophil then. So it's a nice round cell, and the special feature that a neutrophil has is that it's got a very strange shaped nucleus. It's got a multi-lobed nucleus, so understand this is not multiple nuclei. Neutrophils do not have multiple nuclei, unlike the multinucleated giant cells that we saw in the granuloma earlier. Instead, they just have a really strange shaped nucleus, where it's split into these multiple lobes with these little connections in between the lobes. So classically, you have 3-lobed nuclei, but you can have more lobes, so for instance 4 or even 5 lobe nuclei in neutrophils. And for this reason, they're often also known as polymorphonuclear cells. So you can also see neutrophils called PMNs, which stands for polymorphonuclear cells. So poly means many, morpho means shape, nucleus is obvious, so many shaped nucleus cells. So polymorphonuclear cells, or for short, PMNs. So both of these names are referring to the same type of cell, which is the neutrophil. So you have a huge number of neutrophils circulating in the bloodstream, and they're one of the troops that you can recruit from the bloodstream to deal with a pathogen that is infecting your tissue as part of the inflammatory response. So this is one of the major types of cell that we're going to be recruiting. The other major type of cell that we're going to be recruiting is more macrophages. Now, you don't have macrophages just circulating in the bloodstream. Instead, you have a precursor to a macrophage circulating in the bloodstream, which is known as a monocyte. And these are effectively much smaller versions of macrophages, like so. So they have a very big nucleus. The name monocyte is showing the contrast between them and neutrophils, which have multi-lobed nuclei. The monocyte just has a 1-lobed nucleus. And these monocytes, once they've been recruited into the affected area, they can differentiate into macrophages. So let me now show you the process of leukocyte recruitment. So I'll just draw a bit of endothelium here that's been exposed to TNF-alpha and interleukin-1. So we can see that the endothelial cells have contracted here. Here's the basement membrane that they're sitting on. And I've said that this gap is not big enough for the leukocytes just to move through on their own. Instead, what has to happen is they have to interact with the endothelial cells. So what happens is the endothelial cells put on their surface all sorts of molecules which can interact with molecules on the surface of the white blood cells. Okay, so the monocyte will end up binding, monocytes and neutrophils. The leukocyte that's being recruited, whether it's a neutrophil or a monocyte, will end up binding to the surface of the endothelial cells. And then what can happen is the endothelial cells guide the leukocyte through the gap between them, like so. Okay, and this is done through all of the interactions between proteins on the surface of the leukocyte and proteins on the surface of the endothelial cell. And this process of slivering through that gap in this way is known as diapedesis. But you have to understand that the endothelial cells have to interact with the leukocyte in order for this to occur, which is why red blood cells don't do this. So it's another active process involving the endothelial cells, and interleukin-1 and TNF-alpha are going to activate endothelial cells to help monocytes and neutrophils do this. Now, once the monocyte has arrived in the extracellular fluid, it will then differentiate into a macrophage and will become one of these great big blobs of a cell. Okay, so you're bringing in lots of phagocytes, you're bringing in neutrophils and more macrophages. And this is done by interleukin-1 and TNF-alpha activating the endothelial cells of the capillaries and the postcapillary venules to put molecules on their surface which can interact with molecules on the surface of the monocytes and the neutrophils, but not with the red blood cells. Okay, so to overall summarize then what this inflammatory response has achieved. So the alveolar macrophages and the alveolar dendritic cells, they started the inflammatory response off by releasing TNF-alpha and interleukin-1, the cause for help. These acted on the terminal arterioles, the capillaries, and the postcapillary venules in the local area. They caused vasodilatation of the terminal arterioles to increase blood flow to the affected area, and they caused endothelial cell contraction and leukocyte recruitment by the endothelial cells of the capillaries and postcapillary venules. Endothelial cell contraction allows the formation of an inflammatory exudate, which will bring in complement proteins to attack the pathogen that is present. Leukocyte recruitment will recruit us loads of neutrophils and loads of macrophages into the area, and these will then go and phagocytose the mycobacterium tuberculosis cells. So drawing out where we've overall got to at the end of here, so let's say this is a portion of the alveolar duct here, so I'll just colour it in again, so bear with me at this point. So here is the basement membrane of the alveolar cells, and we'll have the type 1 pneumocytes here, maybe we'll have a type 2 pneumocyte here, have another type 1 pneumocyte there, a type 1 pneumocyte there, type 1, and then maybe a type 2 here, and that'll give them nuclei. Okay. And now, because of the inflammatory response that has occurred, we're going to be getting an inflammatory exudate forming, and also lots of these neutrophils and macrophages coming in. So let me now draw these here. So here's a neutrophil. I'll draw another neutrophil here, so you'll bring in loads of neutrophils, and they won't just stay in the area underneath the basement membrane of the alveolar epithelium. I mean, some of them will be in there, but they'll also move into the alveolar spaces as well. And then we'll have loads of these macrophages here. So here are lots of macrophages, and of course they'll all be swimming in an inflammatory exudate, which I'll show here in yellow. Again, they're all here to try and destroy the mycobacterium tuberculosis. So the question now arises, do we think that this is actually going to be successful? Do we think that mycobacterium tuberculosis is going to actually be destroyed by this inflammatory response occurring? Well, the formation of an inflammatory exudate is not going to kill mycobacterium tuberculosis. It is not going to be annihilated by the complement proteins, unfortunately. They're very effective against some microorganisms, but not against mycobacterium tuberculosis. And then we've brought in absolutely loads of neutrophils and loads of macrophages. Well, we know that macrophages aren't really that much use in destroying mycobacterium tuberculosis. The mycobacterium tuberculosis gets the better of macrophages, and it lives inside their phagosomes, divides inside their phagosomes, and then bursts the macrophage open and then spreads to other macrophages. So they're not going to be much use. And the question then is, these neutrophils, are they going to do better? Well, unfortunately, neutrophils are not actually as good as macrophages. You have a huge number of them, but in a way they're almost like the less trained, cheaper form of a macrophage. So if a macrophage isn't going to be capable of killing mycobacterium tuberculosis by phagocytosis, a neutrophil isn't really going to be capable of killing mycobacterium tuberculosis by phagocytosis. I mean, they'll have a go again, they'll phagocytose them up into a phagosome, but again, mycobacterium tuberculosis gets the better of the neutrophils. It prevents the fusion of the lysosomes, it prevents the formation of reactive oxygen species and reactive nitrogen species, lives inside the phagosome, breeds inside the phagosome, and then bursts the cell open and spreads onto new phagocytes. So Unfortunately, we're going to form a fantastic inflammatory response around the area where the Mycobacterium tuberculosis is, but it's not actually going to get rid of the infection. So what we're going to need is the adaptive immune response. So the inflammatory response here is part of the innate immune response, and it has failed to deal with Mycobacterium tuberculosis. And in fact, we're only going to get Mycobacterium tuberculosis under control once we have initiated an adaptive immune response. And the type of adaptive immune response that we are going to initiate is a T helper 1 mediated adaptive immune response, and this is going to result in the formation of granulomas. So we're approaching now the topic of how do granulomas form and why do they form. Okay, to deal with these extremely difficult bacterial species like Mycobacterium tuberculosis. So we will discuss the T helper 1 mediated adaptive immune response in the next video. We will look at how it is initiated and how it is actually going to take effect to form a granuloma, and how that is then going to get the Mycobacterium tuberculosis population under control.